Welcome back to another MI Mental Podcast, Doctors in Court edition. As always, it's Sabine Fonderson, your host. Today, I'm going to examine a case where a missed opportunity to intervene tragically led to the death of a patient. This is the story of Mrs. Martin. Again, it's made-up name, but the cases are real. Mrs. Martin died from septic shock due to a missed gastric perforation after multiple calls for help. It's a tough case that raises questions about communication, clinical judgment, and the challenges of triage in a busy practice. This case is particularly relevant for general practitioners and on-call doctors who face difficult tasks of assessing symptoms remotely and prioritizing care. It's not just a story about what went wrong, it's about what we can learn to improve patient care and prevent such tragedies. Let's dive in. Mrs. Martin was a 72-year-old woman. She had been recovering from a wrist fracture. On January 2009, her son called their GP. As I mentioned in previous podcasts, if there's a GP in the case, I'll call them Dr. Cornelius. The GP was asked to come and perform a house visit because Mrs. Martin was not feeling well. Dr. Cornelius reviewed Mrs. Martin's records, called her directly, and spoke briefly with her son. Mrs. Martin reported gastric pain, nausea, and vomiting, but denied any chest pain or shortness of breath. And Dr. Cornelius concluded that her symptoms were likely gastrointestinal and prescribed ranitidine and metoclopramide. She did not find any urgent reason to visit Mrs. Martin. Later that afternoon, Mrs. Martin's son called again, expressing concern that his mother's condition had worsened. And Dr. Cornelius, noting that there was no new information, reassured him over the phone and asked him to call again if the situation changed. Unfortunately, Mrs. Martin became unresponsive the following day, and by the time emergency services arrived, she was in cardiac arrest and later died in the hospital from septic shock caused by a gastric perforation. Mrs. Martin's son filed a formal complaint against Dr. Cornelius, accusing her of failing to provide adequate care and ignoring repeated calls for help. He claimed that the doctor, the GP, dismissed his concerns and refused to visit his mother despite clear signs of severe medical issue. The GP defended her actions. She stated that she based her decision on the information available at the time. She argued that Mrs. Martin's symptoms did not indicate an immediate emergency and that her approach was consistent with standard practice for non-specific gastrointestinal complaints. And this case isn't just about medical decisions, it's about how we communicate with patients and their families in moments of uncertainty. So let's take a closer look at the court's findings. The court ruled that Dr. Cornelius' actions did not constitute negligence. They acknowledged that the GP reviewed the patient's records, spoke directly with Mrs. Martin, and made a reasonable judgment based on the symptoms described. However, the court also noted that the son felt unheard and dismissed. They highlighted that communication failures can create a sense of abandonment for families, even when the doctor's clinical decisions are defensible. Ultimately, the court dismissed the complaint, stating that while the outcome was tragic, the GP acted within the bounds of professional standards based on the information available. But still, this case underscores the importance of recognizing subtle signs of serious conditions like septic shock. Septic shock, often caused by an untreated infection like a gastric perforation, progresses rapidly. Early symptoms like abdominal pain and nausea can be deceptively mild, making it difficult to diagnose without further evaluation or imaging. And the challenging thing for GPs is triaging symptoms remotely, and studies have shown that septic shock mortality increases by 7.6% for every hour of delayed treatment. In this case, if a visit or referral had been made earlier, imaging might have reveal the gastric perforation in time for surgical intervention. Ethically, this case highlights the importance of listening to caregivers. And while Mrs. Martin's son's concerns didn't include new clinical information, his persistence should have signaled a deeper need for reassurance or escalation of care. A 2022 study in BMJ Open emphasizes the importance of using early warning score systems for patients presenting with ambiguous symptoms over the phone. And tools like News2, the National Early Warning Score, can help flag signs of deterioration that warrant urgent attention. Another critical approach is shared decision-making. When patients or families are insistent, involving them in a collaborative plan, like scheduling a visit just in case, can prevent oversight and it helps to build trust. And for GPs, ongoing education on identifying subtle signs of septic shock or other life-threatening conditions is crucial. And for families, understanding when and how to advocate effectively can make all the difference. So what are some take-home messages here? For health professionals, err on the side of caution. When in doubt, consider a visit or a referral, especially with elderly patients. Use tools to support decisions. Use a scoring system like News2. Use tools to support decision. There are many tools available, again, depending on which country you're practicing medicine, but there are scoring systems that can guide triage decisions. Number 3, prioritize communication. Listen to family concerns, and because the information they provide can be critical in the context of clinical decisions. And for patients and families, you need to be persistent. If you feel something is seriously wrong, don't hesitate to insist on further evaluation and communicate clearly. Describe symptoms in detail and express why you're concerned. I'm going to leave you with some thought-provoking questions. First, as health professionals, how do you balance the need to prioritize urgent cases with the risk of underestimating non-specific symptoms like vulnerable patients? As a general practitioner, I find that triage is really important, and I use triage scoring tools to help assess the probability of somebody getting worse. There are also early warning tools that can be used, and combining that with clinical judgment will help minimize risk. One of the things that is important, especially when it comes to elderly care or people who are elderly, is to first of all find out, have they been recently admitted in hospital? What other comorbidities do they have? And really important is, especially for elderly patients, it really makes a lot of a difference for the family if you just go and take a look. What I do, and I tell that to my staff, if their gut feeling says there's something that they cannot put their finger on and they want me to go and do a home visit, I go. I never doubt a home visit, because at the end of the day, the first person that a patient or family member might contact the practice is an assistant. And by the time that information comes to me, a few hours may have passed, or the interpretation of that information would have been different. So if my assistant says, I have a gut feeling that things are not going well, can you do a visit? I will do a visit. Second question, how can families advocate for better care without creating conflict with their care providers? And what strategies can foster collaboration and trust? In several cases where patients are quite vulnerable, again, I use the example of those who are elderly. I tell family members that it's really important that they communicate with me or the assistant. And if they feel the need to raise an alarm because they don't trust the situation, they know that with me is going to be low threshold to get me involved. And because I also involve other team members, I think it's important, especially in general practice, to have multiple eyes looking at a patient, particularly in cases of vulnerable patients. Now, in a general practice, you will have a doctor's assistant, you might also have a nurse practitioner, and it's not unusual for me to involve the nurse practitioner and say, right, I've been to this patient, I find that this patient is quite vulnerable because A, they live alone, or the family members are quite far away, or they've just been hospitalized and they come back, and their husband or spouse is the main carer. So I tend to early on already start signaling things that I feel will only add more to the vulnerability. And at the point where something deteriorates, I say to my staff and to my team, let's go and take a look. It's much better to be there on time and prevent things from getting worse than assuming that things are going to improve based on the information that you get. So this case is really another example of reminding us how complex care within a general practice setting can be. While not every outcome can be prevented, communication, vigilance, and compassion can also go a long way to improve the care. Before I leave, I want to summarize an article on gastric emergency in older adults. It's written by Rosa and colleagues and published in the BMJ Open in 2022. This study investigates outcomes in older adults presenting with gastric emergencies, such as gastric bleeding and perforations, in a hospital setting. It focused on patients aged 65 to 79 versus those aged 80 and older, and explored differences in clinical presentations, treatments, and outcomes. So what are the main findings? Number one, increased risks in older adults. Patients older than 80 years had higher rates of shock, 10.9% versus 5.1%. They had higher rates of gastric perforations, 3.6% versus 0.2%, and cumulative comorbidities compared to younger cohorts. The second key finding, outcomes between age groups. Despite higher severity at presentation, mortality rates and length of hospital stays were comparable between the two age groups when treatment was given on time. The third key findings are predictors of poor outcomes. Factors like presenting with septic shock, gastric malignancy, and gastric fistulas were significantly associated with mortality. The fourth key finding was management strategies. Endoscopy and surgery were pivotal for managing gastric bleeding and perforations, and non-operative management, NOM, was considered viable for small perforations without diffuse peritonitis, but required careful patient selection. And the last key finding is the importance of timely intervention. And delays in treatment, particularly for surgical cases, significantly impaired survival, with mortality increasing by 2.4% per hour of delay beyond the first 24 hours. So this study provides critical insights into Mrs. Martin's case, where a misdiagnosis of gastric perforation led to septic shock and her untimely death. And here's how the findings align. The study highlights shock as the most significant predictor of poor outcomes in gastric emergencies. In Mrs. Martin's case, the early symptoms of her perforation, vomiting, and abdominal pain should have prompted suspicion, as these often precede systemic shock. The authors of the study emphasized the need for prompt CT imaging or endoscopy in suspected gastric emergencies. The absence of immediate diagnostic steps in Mrs. Martin's case represents a missed opportunity to intervene before septic shock set in. The study supports non-operative management only in carefully selected cases, and for Mrs. Martin, who presented with symptoms indicative of possible peritonitis, immediate surgical evaluation would have been a safer course of action. And finally, the study underscores the multidisciplinary nature of gastric emergency management. In Mrs. Martin's case, better coordination between the GP, emergency services, and hospital specialists could have led to faster diagnosis and treatment. So what are the lessons for general practice? First of all, symptoms like persistent abdominal pain, vomiting, or signs of systemic illness in elderly patients should raise alarms for gastric perforation or other emergencies. For at-risk patients, early imaging and endoscopic evaluation should be prioritized, especially when symptoms escalate or do not resolve with conservative treatment. As in Mrs. Martin's case, repeated family concerns should have been taken seriously, even when clinical findings were inconclusive. Prompt escalation to specialized care can prevent delays. And this study confirms that delays beyond 24 hours significantly worsen outcomes in cases requiring surgical intervention. And this reinforces the need for efficient triage and referral systems in primary care. And the main takeaway message for this podcast, and in particular for health professionals, is to recognize shock as a red flag in gastric emergencies and to balance conservative and interventional management based on patient risk factors and diagnostic findings. And the takeaway message for families and caregivers is that they need to understand that persistent or worsening symptoms really do require urgent attention, and they need to be able to advocate that so that imaging or specialist care can be flagged up on time. Thank you again for joining me on the MI Mental podcast, the Doctors in Court edition. As always, let's keep learning from these cases to better serve our patients and their families, and to also become better doctors. See you next time. Thank you.